Assalamualaikum and salam sejahtera. I be to Madam Hairina. So we are from group 5 and we will present about the interrelationship of skeletal and muscular system of a shoulder. So meet our group member that consists of 5 persons, which is Akila, Nurin, Zulaika, Adriana and also Putrantan. We will begin to explain about the anatomical and biomechanical of the shoulder. Begin with how the shoulder related to each other, how it's sweet to perform their function. Next, we have the physiology of the muscle contraction, and lastly, the radiograph for basic projection of the shoulder. So, Akila, we will begin this video presentation with describing all the anatomies of shoulder.
Assalamualaikum everyone, I'm Nurul Akila Minta Halim. Today, I will be presenting about the anatomy of the shoulder girdle. Let's begin with an overview of the shoulder joint. The shoulder is one of the most structurally and functionally complex joints in the human body. It provides an exceptional range of motion including flexion, extension, abduction, and adduction, and rotation, making it highly mobile. The shoulder joint is classified as a ball and socket synovial joint where the head of humerus fits into glenoid cavity of the scapula. However, this mobility comes at a cost. It also the most prone to dislocation among all joints. The bone involved in the shoulder girdle are the clavicle or collarbone, the scapula or shoulder blade, and the humerus, which articulate with the scapula at the glenoid cavity. The scapula or shoulder blade is a flat, triangular bone located in the upper back. It connects the humerus with the clavicle and plays a major role in both stability and mobility of the shoulder. From the anterior view, we can identify the subscapular fossa, coracoid process, glenoid cavity, supraglenoid and infraglenoid tubercles, and the scapular notch. From the posterior view, the key features are the spine, supraspinous and infraspinous fossa, and the acromion. We also observe three borders, superior, medial, and lateral, and triangle, superior, lateral, and inferior. These are essential anatomical landmarks. Next is the clavicle or collarbone. This long S-shaped bone is located at the base of the neck. It connects the upper limb to the exoskeleton by joining the scapula and the sternum. The clavicle supports the shoulder, protect neuromuscular structure, and serve as muscle attachment site. From the superior view, we identify the acromion and lateral, which articulate with the scapula, the sternal and medial, which connect to the sternum, and the shaft, the long middle part of the clavicle. From the inferior view, we see structures like the cunoid tubercle and trapezoid line, which are ligament attachment site, the subclavian groove, and the costal tuberosity. Next, let's move to the humerus. The humerus articulate with the scapula at the shoulder girdle. At the proximal end, we find the head, which fits into the glenoid cavity, the greater and lesser tuberosity for muscle attachment, the bicipital groove for the long head of the bicep and brachii tendon, and the pectoral ridge. In the shaft, we note the deltoid ridge where the deltoid muscle attach, and at the distal end, important features include the epicondyle for muscle attachment, the capitulum and trochlea, which articulate with the radius and ulna, and fossa for the olecranon, coronoid, and radial process. Next, the articular surface of the shoulder joint is covered by a hyaline cartilage which reduces friction and absorbs shock. It includes the head of humerus and the glenoid cavity of the scapula. The attachment capsule is thin and loose, which allows for a wide range of motion. Laterally, it attaches to the anatomical neck of the humerus. Medially, it extends to the scapula beyond the margin of the glenoid cavity. Finally, let's move to the shoulder muscle, ligament, and tendons that attach to the shoulder girdle. The muscles supporting the shoulder include the deltoid, trapezius, pectoralis major and minor, and the bicep brachii. key ligaments include the coracoclavicular, coracoacromial, acromioclavicular, and the glenohumeral ligament. The tendons involved are the rotator cuff tendon and the bicerebral key tendons. These structures collectively provide the strength, stability, and movement of the shoulder joint.
Biomechanical perspective of shoulder are complex. They involve muscle of the glenohumeral, scapulothoracic, and thoracohumerus group. Let's start with a glenohumeral joint. Glenohumeral joint is a ball socket that articulates the humerus and the scapula. It was involved two movements, which is elevation and abduction. So, during forward elevation, the deltoid and supraspinatus muscle will contract to create a vertical shear force to hold the humeral head in the joint and minimize the humeral head translation. Other than that, the supraspinatus is responsible for initiation of abduction with deltoid muscle to achieve full shoulder abduction and allow the greater tuberosity to clear to the acromion. Scapulothoracic joint, a joint that is formed by the scapula and the thoracic cage between second and seventh rib. So this joint allow a biomechanical wide arch of motion but be stable to allow the force vector to be guided through the glenoid fossa. In this slide, I highlight three important functions of a normal scapular rotation. Besides that, sternoclavicular joint formed by the clavicle articulating with the manubrium of the sternum and the first costal cartilage. This joint allows for elevation and depression of the shoulder. For example, it allows for 45 to 16 degrees of elevation and 5 degrees of depression. Apart from that, elevation is limited by a tension on a costoclavicular ligament, while depression is limited by a superior joint capsule and interclavicular ligament. And lastly, acromioclavicular joint. This joint is a gliding joint with a cartilaginous disc between the acromion and the clavicle. So most of the movement at the SCJ is a rotation movement. This is proved by the clavicle will rotate approximately 15 degrees posteriorly with elevation of the shoulder and additional 8 degrees of rotation through the SCJ. Other than that, the ACJ is stabilized by the acromioclavicular ligament for horizontal stability and coracoclavicular ligament for vertical stability.
Assalamualaikum and hi, I am Baki Zulaika and I will continue this presentation regarding the shoulder attachment. I will explain on how each joint on shoulder part attaches to each other or assigned to each other. Now we will start with the first joint, which is glenohumeral joint. This joint is also known as ball and socket joint. We will see on how glenohumeral joint, which is ball and socket joint, articulate the humerus and the scapula. This joint allows wide range of shoulder movement. There are mainly three ligaments involved in glenohumeral joint. The first one is superior glenohumeral joint or SGHL, following by middle glenohumeral ligament, which is MGHL, and lastly is inferior glenohumeral ligament, which is IGHL. So the first one, superior glenohumeral ligament, also known as SGHL, plays an important role in keeping the shoulder stable in its lower ranges of motion, especially when it comes to moving down. Besides, middle glenohumeral joint or MGHL, the middle part of the joint, also placed in between IGHL, which is inferior glenohumeral joint, and superior glenohumeral joint, SGHL, take part in stabilizing both superior and inferior glenohumeral joint. Also, the anterior portion of the shoulder capsule, MGHL, also helps in limiting excessive external rotation on the shoulder. Lastly, inferior glenohumeral joint, which is IGHL, helps in stabilizing the shoulder during abduction and external rotation. So, IGHL consists of intermediate axillary pouch, a posterior band, and anterior band as shown in diagram below. Moving on to the sternoclavicular joint or SC joint. This joint connects the clavicle to the sternum, and it also allows movement of the shoulder girdle. There are three main ligaments involved in this joint, which are interclavicular ligament, anterior and posterior sternoclavicular ligament, and the last one is costoclavicular ligament. So the first one, interclavicular ligament, helps in strengthens the joint capsule superiorly and also attached to the sternal end of both clavicle. Meanwhile, the anterior and posterior sternoclavicular ligament plays an important role in making sure the joint capsule is strengthened anteriorly and posteriorly. And the last part of the sternoclavicular joint, which is costoclavicular ligament, helps in attach the first rib and costal cartilage to the inferior surface of the clavicle. This ligament also considered as a primary stabilizing factor for the joint, also preventing an elevation for the pectoral girdle. Next is acromyoclavicular joint, or also known as AC joint. The first ligament of this joint is acromyoclavicular ligament. It connects the acromion to the clavicle and offers both vertical and horizontal stability for the AC joint. Next is CCL ligament, or known as coracoclavicular ligament, can be divided into two, which are conoid and trapezoid ligament. Conoid ligament extends from the clavicle's underside vertically to the coronoid process. In the meantime, the trapezoid ligament extends more horizontally from the coracoid process to the clavicle. Both of these ligaments suspend the scapula from the clavicle and prevent excessive rotational and vertical displacement. Last but not least, CAL, or coracoacromial ligament, also one of the AC joint, and it forms the coracoacromial arc by extending from the coracoid process to the acromion. It also helps in preventing superior dislocation of the humeral head. Muscles that are assigned on shoulder are rotator cuff, including supraspinatus, infraspinatus, teres minor, and also subscapularis. Other than that, muscles involved are pectoralis minor, pectoralis major, deltoids, trapezius, and serratus inferior. That's all from me. The next part will be continued by other presenter. Thank you.
So next, I'll be explaining about how the shoulder are well suited to perform their function. The shoulder itself is a ball and socket joint whereby will give us a wide range of motion and in multiple direction. However, these movements need many types of bone, joint, and ligament to keep its stability. So we will begin with the anatomical of the bone. This bone connect the upper limb to the axial skeleton. So I will begin with the clavicle, or known as collarbone. It is a S-shaped bone that connect medially to the sternum and laterally to the scapula, and it works in elevating and depressing the shoulder as well as give a great range of movement to the arm. Then scapula looks like a shoulder blade, which is a flat bone that acts as the house of glenoid fossa. It works as a shallow socket where the head of humerus fits to form a ball and joint socket to allow the shoulder to move. Next, moving on to the joint, it plays a vital role in coordinating both stability and mobility to allow smooth and control the arm movement. I'll begin with the first joint, which is sternoclavicular joint that connects the clavicle to the sternum, which enable the elevation and depression of the clavicle. The second one is acromyoclavicular joint. This joint links the clavicle to the scapula, which allowing any gliding and slightly rotational movement. Lastly, the most important one is clonohumeral joint. Clonohumeral joint, which is a true ball and socket joint between the scapula and head of humerus, it works to provide the shoulder with its wide range of motion across the multiple planes. Then, basically, as you can see at the right side of this slide, it shows the example of how well it works during reaching overhead. Firstly, the movement begins with the AC joint will elevate the clavicle. It follows by rotation of the scapula at the AC joint itself. And finally, the clonohumeral joint will abduct the arm and completing the motion smoothly. So we already at the end of this part. Last but not least, we have the ligaments. Ligaments which are part of the shoulder that plays a crucial role in maintaining shoulder stability while allowing a wide range of motion, and it also helps to prevent injuries. I begin with clonohumeral ligament. It is supported by three key ligaments, which is superior, medial, and also inferior. The first one is superior glenohumeral ligament, which is SGHL, attached from the glenoid to the lesser tubercle of the humerus, and it helps to prevent the inferior dislocation when the arm is relaxed. Then the medial glenohumeral ligament works to stabilize the joint when the arm is abducted around the 50 degrees and resisting the anterior movement. Meanwhile, the inferior glenohumeral ligament is the main restraint against the anterior-inferior dislocation, especially when the arm is raised above 90 degrees. In addition, the acromyoclavicular ligaments is made up of trapezoid and also clonoid ligaments. It helps to stabilize the AC joint by connecting the coracoid process of the scapula to the clavicle. Finally, the coracohumeral ligament. This ligament extends the coracoid process to the humerus, which works to reinforce the superior part of the joint capsule. All in all, I can conclude that these ligaments works as a team to ensure that the shoulder remains strong, strapped, and also flexible even during complex or high mobility of movement. So for the next part, Putri will explain more about the muscle physiology.
I will be explaining to you about the physiology of muscles for shoulder. Your shoulder muscles are skeletal muscles. Tendons attach them to bones. There are voluntary muscles, meaning you control how they move and work. First thing first, what is the purpose of the shoulder muscles? The shoulder muscles serve a variety of functions, including holding the bones of your shoulder joint in place, moving your arms up, down, forward and backward, protecting your shoulder joint, and rotating your shoulder. What are the shoulder muscles made of? Like other muscles in your body, shoulder muscles contain lots of elastic fibers. These fibers give them flexibility and allow them to contract. They are red and white, so they look striated. Muscle contraction is the tightening, shortening or lengthening of muscles when you do some activity. It can happen when you hold or pick up something, or when you stretch or exercise with weights. Muscle contraction is often followed by muscle relaxation when contracted muscles return to their normal state. Next, I'm going to explain about shoulder movement and the muscles involved. So, the main movements of the shoulder include flexion, extension, abduction, adduction, internal rotation, external rotation, and circumduction. Without further ado, let's take a look at the first movement, which is shoulder flexion. It is a movement of the shoulder in a forward motion. The brain gives commands to lift the arm forward. Hence, the nerve signal from the brain reaches the spinal cord and then to the shoulder muscle. Then muscle contraction happens. The movement is accomplished primarily by the combinations of the contracting muscles and the relaxing muscles. During flexion, the contracting muscles is anterior deltoid, pectoralis major, coracobrachialis, and biceps brachii muscle. Whereas the relaxing muscles is posterior deltoid, latissimus dorsi, teres major, and triceps brachii. Second movement is extension, which is opposite to flexion. It is the movement of the arm moved directly behind the body, which the brain commands to lift the arm backward. The nerve signal from the brain reaches spinal cord and then to the shoulder muscle. During extension, the contracting muscles is posterior deltoid, latissimus dorsi, teres major, and triceps longhand. Whereas the relaxing muscle is anterior deltoid, biceps brachii, and pectoralis. The movement is abduction. It is the movement of lifting your arm away from the side of your body. The brain commands to lift the arm to the side. The nerve signal from the brain reaches spinal cord and then to the shoulder muscle. Then shoulder muscle contract. During abduction, the contracting muscles is deltoid and supraspinatus. Whereas the relaxing muscles is pectoralis major, latissimus dorsi, teres major, and coracobrachialis. Fourth movement is adduction, which is opposite to abduction. It is the movement of bringing your arm back down to your side. The brain commands to bring arm to the body. The nerve signal from the brain reaches spinal cord and then to the shoulder muscles. The contracting muscles involved is pectoralis major, latissimus dorsi, teres major, triceps, and coracobrachialis. Whereas the relaxing muscles is deltoid and supraspinatus. Fifth movement is external rotation. It is the movement of rotating the upper arm outward. The brain will commence to rotate arm outward the body. The nerve signal from the brain reaches spinal cord and then to the shoulder muscle. The contracting muscles involved is posterior deltoid, teres minor, and infraspinatus muscles, whereas the relaxing muscle is subscapularis, pectoralis major, latissimus dorsi, and teres major. Next, the sixth movement is internal rotation, which is the opposite of external rotation. It involves rotating the upper arm inward toward the center of the body. When the brain sends a command to rotate the arm inward, nerve signals travel from the brain to the spinal cord and then to the shoulder muscles to initiate the movement. During internal rotation, the contracting muscles involved is pectoralis major, latissimus dorsi, anterior deltoid, teres major, and subscapularis. Meanwhile, the relaxing muscles are infraspinatus, teres minor, and posterior deltoid. Lastly, circumduction, a circular movement that combines all the above movements, which is flexion, extension, abduction, and adduction in sequence. The brain will commence to move the arm in circular movement. The nerve signal from the brain reaches spinal cord and then to the shoulder muscle. All the major shoulder movers and stabilizers, including the rotator cuff muscles, work in coordination. During circumduction movement, these muscles function together harmoniously. So that's how the physiology of shoulder muscle happens.
Let's take a look at this diagram of shoulder, which illustrates both anterior and posterior view. As we know, the human body has a two pectoral shoulder girdle that attach the bone of the upper limb to the axial skeleton. It's clearly shown in this diagram. Each of the two pectoral girdle consists of a clavicle and a scapula, which articulate with the proximal humerus. The clavicle is the anterior bone and articulate with the manubrium of the sternum at the sternoclavicular joint, while the scapula is articulate with the clavicle at the acromyoclavicular joint and with the humerus at the glenohumeral joint. Apart from that, the pectoral girdle do not articulate with any vertebral column and are held in a position to stabilize by a group of a large muscle that extend from the vertebral column and ribs to the scapula. Next, we move to the next presentation, which is the radiographic image of the basic shoulder, which is AP, lateral, and scapula-wide projection. AP projection is the most common view for the shoulder. In the externally rotated position, the patient hand is supinated and the epicondyle of the humerus are parallel to the image receptor. In this radiograph, it shown clearly the greater tubercle is clearly visualized in a profile laterally, while the lesser tubercle is superimposed over the humeral head. Apart from that, the scapula-humeral joint space is open. And in this radiograph, it also shows the proximal humerus, glenohumeral joint, acromyon, and a coracoid process are well demonstrated. And lastly, the head of humerus should be centered to the glenoid cavity without rotation. A lateral projection of the shoulder. This projection is performed by rotating the arm internally and the humeral epicondyle will perpendicular to the image receptor. In this radiograph, it clearly shows that the lesser tubercle now appears in a profile medially and the greater tubercle is superimposed over the humeral head. It also visualizes the scapula-humeral joint, acromyon, and a coracoid process clearly. The proximal humerus is visualized down to the cervical. This slide shows the scapula-wide lateral projection, which is a special view primarily used in a trauma setting to assess for a shoulder dislocation or a scapular fracture. In this radiograph, it shows clearly the humeral head is superimposed over the glenoid cavity and the acromyon is projected laterally, while the coracoid is anteriorly. The body of the scapula is visualized as the vertical limb of the Y, and there is no significant rotation visible in this radiograph. So that brings us to the end of the presentation, and thank you for all your time and